Lower back pain is a common complaint worldwide, and one of its leading causes is lumbosacral herniated nucleus pulposus, or HNP. This condition involves the displacement of the gel-like nucleus pulposus from the intervertebral disc, most often at the L5S1 level. The result is irritation or compression of nearby nerve roots, which can cause pain, numbness, and weakness radiating into the lower limbs. Understanding the clinical characteristics and neurophysiology of lumbosacral HNP is crucial for accurate diagnosis and effective treatment. Lumbosacral HNP is particularly significant because it affects a large portion of the population, especially adults who are active or have jobs involving physical labor. The L5S1 segment is especially vulnerable due to its mobility and the mechanical stress it endures. Patients often present with symptoms that can disrupt daily life, such as persistent lower back pain, tingling, or muscle weakness. Recognizing the prevalence and impact of this condition helps clinicians prioritize early detection and intervention. Lumbosacral HNP, the nucleus pulposus pushes out of its normal space and enters the spinal canal. This displacement can either irritate or compress the nerve roots. Irritation typically causes pain and sensory changes, while compression can lead to more severe symptoms like muscle weakness or loss of reflexes. The distinction between irritation and compression is vital, as it influences both the urgency and type of treatment required. Electromyography, or EMG, is a key diagnostic tool for evaluating patients suspected of having lumbosacral HNP. EMG is non-invasive and relatively affordable, making it accessible for initial assessments. By measuring the electrical activity of muscles supplied by specific nerve roots, EMG helps clinicians localize the site of nerve involvement and distinguish between root irritation and compression. This functional information complements imaging studies, providing a more complete picture of nerve health. Beyond standard EMG, specialized tests like the F-response and H-reflex offer deeper insights into nerve conduction. The F-response measures the backfiring of motor neurons after electrical stimulation, while the H-reflex assesses reflex arcs similar to the ankle jerk. These tests are particularly valuable for evaluating the integrity of both peripheral and central nervous system pathways, helping to detect subtle abnormalities that might not be visible with other diagnostic methods. Combined use of EMG, F-response, and H-reflex is especially useful in confirming L5S1 radiculopathy. These tests validate the presence of nerve root involvement and help distinguish between irritation and compression. This distinction is crucial for tailoring treatment strategies, which can range from conservative management to surgical intervention. By providing a comprehensive assessment, these neurophysiological tests enhance diagnostic accuracy and improve patient outcomes. Study used an analytic cross-sectional design, recruiting patients with lumbosacral HNP through consecutive sampling. This approach ensured a broad representation of individuals with the condition, minimizing selection bias. The main focus was on evaluating nerve conduction velocity (NCV) and the electrophysiological responses of F-reflex and H-reflex. By systematically assessing these parameters, the study aimed to clarify their diagnostic value in distinguishing between irritation and compression lesions. Each patient underwent a thorough neurophysiological assessment, including measurements of NCV, F-response, and H-reflex. These tests were performed systematically to ensure consistency and reliability. The collected data were then analyzed and compared between two key lesion types, irritation and compression. This process provided a clearer understanding of how nerve conduction changes in different pathological conditions associated with lumbosacral HNP. Study measured several key neurophysiological parameters: compound muscle action potential (CMAP) values for the tibial and peroneal nerves, as well as sensory nerve action potential (SNAP) values for the sural nerve were recorded. These included latency, amplitude, and nerve conduction velocity. Understanding these parameters is essential for interpreting the results and identifying abnormalities in nerve function. Among the 50 patients studied, the average values for motor and sensory nerve conduction were within normal limits. For example, the tibial nerve showed a latency of 4.47 ms, amplitude of 6.59 mV, and NCV of 53.95 ms. The peroneal and sural nerves also demonstrated normal values. These results suggest that, in many cases, standard nerve conduction studies may not reveal significant differences between irritation and compression lesions. Study found significant differences in F-response and H-reflex values between patients with compression lesions and those with irritation lesions. In compression lesions, both F-response and H-reflex parameters were significantly altered, indicating proximal nerve conduction impairment. However, in irritation lesions, these parameters remain largely unchanged. This highlights the sensitivity of these tests in detecting nerve compression. Statistical analysis confirmed that F-response and H-reflex tests are effective in differentiating between compression and irritation lesions. The p-values for these tests were less than 0.05 in compression cases, indicating a significant difference. In contrast, standard nerve conduction parameters such as CMAP and SNAP did not show significant differences. This finding underscores the importance of reflex-based assessments for sharper diagnostic detection. The ability to distinguish between compression and irritation lesions has important clinical implications. Patients with clear reflex abnormalities indicating nerve compression may require more urgent or aggressive treatment, such as surgical decompression. In contrast, those with irritation lesions and normal reflex parameters may be managed conservatively. This targeted approach helps optimize patient outcomes and resource allocation. Findings of this study are supported by previous research. For example, studies by Sadik and Tawa have shown that H reflex and F response are sensitive indicators of proximal nerve conduction disturbances, especially in compressive neuropathies. International studies also confirm that combining reflex tests improves diagnostic accuracy and prognosis evaluation in lumbar radiculopathy patients. Interestingly, the study found that distal nerve function, as measured by standard NCV tests, is often preserved in early stages of lumbosacral HMP. This means that patients may have normal motor and sensory conduction despite significant proximal nerve root involvement. As a result, clinicians should pay close attention to reflex-based assessments for early detection of nerve compression. Results of F response and H reflex tests can help guide treatment decisions. Patients with significant reflex abnormalities may benefit from surgical intervention, while those with normal reflexes can often be managed with physical therapy and medications. This approach ensures that each patient receives the most appropriate and effective care based on their specific neurophysiological profile. While the study provides valuable insights, it is important to acknowledge its limitations. The cross-sectional design and relatively small sample size may affect the generalizability of the findings. Additionally, confounding factors such as patient comorbidities or variations in testing techniques could influence the results. Future research with larger, prospective studies is needed to validate these conclusions. The authors have declared that there is no conflict of interest related to the publication of this research. This transparency is important for maintaining trust in the scientific process and ensuring that the findings are unbiased and reliable. This research did not receive any funding from government or private sectors. The authors express their gratitude to all patients, contributors, and supporters who made the study possible. Such acknowledgments highlight the collaborative nature of scientific research. Summary: the study demonstrates that F response and H reflex examinations provide valuable information for differentiating between compression and irritation lesions in lumbosacral HMP. While standard nerve conduction studies may appear normal, reflex-based assessments can reveal subtle but clinically significant abnormalities. These findings support the use of comprehensive neurophysiological testing in the evaluation of patients with lower back pain. As research continues, the integration of advanced neurophysiological tests into routine clinical practice will likely improve the diagnosis and management of lumbosacral HMP. Clinicians are encouraged to stay informed about emerging evidence and to apply these insights to enhance patient care. Ultimately, a deeper understanding of nerve conduction and reflex responses will lead to better outcomes for those suffering from lower back pain.